COMT inhibitors we do use. So this is another enzyme which breaks down levodopa before it gets to the brain. And you can use, there's 2 different kinds in New Zealand, entacapone, tolcapone. Entacapone is 200 milligrams 3 times a day. So it might give you another half an hour to an hour of extra effect. All it does is just boost the amount that gets to the brain. And so it's not a miracle sort of treatment. The side effects can be significant, so gastrointestinal mainly. It makes the urine go an orangey sort of colour, and you just tell patients about that. It doesn't damage the kidneys or anything, just makes it go a strange colour. And there's another one called tolcapone. Tolcapone is actually much better. It's more effective, more potent, but there's a very uncommon, very rare side effect of liver failure. So it got pulled in the UK, I think, because there were a couple of patients died of liver failure. So you have to do 2 weekly LFTs to have that one for a while. So it's a bit of a pain. But it can be really good. Amantadine is a funny kind of drug. It was invented as an antiviral medication, and they just serendipitously noticed that it had these positive benefits of Parkinson's disease. And people don't really know exactly how it works. It's multiple neurotransmitters. Works in dopamine, noradrenaline, serotonin, but all these hormones are involved with Parkinson. And its main indication is to reduce dyskinesias. So dyskinesias are the abnormal choreiform writhing sort of movements people get when they've had Parkinson's for a while and they're given levodopa. And so this can settle those down. It also has a slight alerting effect, so people find it gives them a bit of a boost during the day. So I often tell people to take it maybe in the morning, lunchtime, early afternoon. You don't want to take it later than sort of 5 p.m. because it might keep you up at night. And it does have anticholinergic properties as well. So elderly people with bladder dysfunction, other things may not tolerate it, or prostate problems, I should say. Yeah, that's enough about that. That rash is livedo reticularis, so side effect, you can get that rash, and you also can get some ankle edema, but it doesn't cause a heart failure or anything. Anticholinergics are quite limited in their usefulness, as I said, because of the side effects. So all the anticholinergic side effects, people with Parkinson's already have half of these anyway, so you're sort of in trouble. I often stop them if someone's progressed, just because they don't really do a whole lot. The only thing they improve with really is the tremor. They may help people hold on to the urine a bit better as well. So urinary urge, I often use some anticholinergics for that. The other thing you can do for that is inject the bladder with Botox if it's really bad. It can be quite effective. Cognitive dysfunction has got very limited evidence in terms of medical treatment in Parkinson's diseases. There's been a couple of meta-analyses and things which have suggested these acetylcholinesterase inhibitors could be somewhat useful, but I just say that the evidence is pretty scant and I don't really use it very much at all. It's important though that the underlying Parkinson's, their dopamine deficiency is treated, and most importantly if they've got any depression or anxiety that is treated, because that can really impact on their cognitive function. So with the mood, there's different medications you can use, and there is evidence that it works in Parkinson's disease. SSRIs are sort of a mainstay. I personally quite like mirtazapine. I find it's a really good one for a number of reasons. Firstly, it's taken at night time before we go to sleep, and so it can give people a sort of slight sedating effect. It also works on noradrenergic and serotonergic pathways, which are also low in Parkinson's disease. And I find people sort of tolerate it a bit more. And it works a bit better. So I love that one. Start at 15 milligrams, and sometimes that's enough. Yeah, you can go up to 30, but most of the time 15 is fine. Yeah, and you often find people on lots of benzodiazepines, which sometimes they need because it's just terrible nights, and you have to, do something for these REM sleep behaviour disorders. But during the day, it can be problematic. Hallucinations and psychosis. I mentioned that quetiapine and clozapine have got the best track record for having less extrapyramidal side effects. So all the other ones can really worsen Parkinson's disease. So I usually start with quetiapine and then build up to clozapine, which is actually a really good drug for psychosis and Parkinson's. There's a new one overseas, pimavanserin, which we don't have access to, but that's quite good because it doesn't block dopamine at all. It only works on serotonin, and it's been trialled specifically in Parkinson's. Restless leg syndrome. Sorry, I was getting a little bit didactic and a bit long. We'll get some videos soon, hopefully. Restless leg syndrome, talked about, it's a pretty horrible thing, and it can respond really well to dopamine agonists as the first line. So usually I'd start with some pramipexole at night, just with a very low dose, like 0.25 milligrams, and go up from there. And levodopa also works. Both of these dopamine medications can have augmentation. That's where you get less effect over time. We don't have a reticotine patch in New Zealand, but that's quite a good, easy treatment for people because they just pop the patch on, then it's done. Gabapentin can be effective as well. Now we have pregabalin too, but you really need to crank the dose up quite high to get a benefit. I've never actually used the combination of oxycodone and naloxone myself, but I've got a couple of people I'm starting to think about it because nothing else is working or they're intolerant, and it can be quite horrible. Important to point out secondary causes of restless leg syndrome, so iron deficiency. So always check for iron because that can cause it by itself. Strange, I don't know why, but it does. And so other treatments. So we talked about Cialarrea drooling is really problematic, and there's different things you can try. If it's only mild and someone's pretty good, sometimes chewing gum works. That's strange, but it's not that they're producing more saliva, it's just that they are not clearing it. So if you can do something to help them moving their mouth, then just chewing gum sometimes is all you need to do. So you can say sugar-free, extra, or whatever. Beyond that, there's other tricks you can do. So if someone's not got severe cognitive problems, you might try some atropine eye drops. So you get a drop of atropine onto the finger and just rub it around the gums. Just one drop, not drops into the mouth, or you have problems. But that can work really well, and it can last for a few hours. The other thing some people try is Atrovent inhaler. Again, it's anticholinergic. You just sort of puff it into the mouth and hold it in the mouth for 10 or 20 seconds. And if it's really bad, beyond that, we do inject the salivary glands with Botox. Do that in Botox clinic, and that can be quite good as well. But it's just quite a disabling thing. Melatonin can help people with REM sleep behaviour disorder. Talked about clonazepam. Caffeine actually has some evidence in Parkinson's disease. It can sort of give people a boost in the morning, so I'm not against people having a nice cup of coffee to get them going. It's fine. It's probably similar to Amantadine, it works in similar pathways. And unfortunately, so there's some things which don't respond very well to treatment. So postural instability doesn't respond very well to medications, and these are sort of negative trials. I'd almost delete those. You can try anything you like with increasing the dopamine medications. People are still going to fall over. So you need to get the rehab team involved. They may need walking frames, that kind of thing. Okay. Things which have been shown to provide benefit are exercise. So exercise is something simple to prescribe. It's probably got the most evidence as a disease-modifying treatment in Parkinson's. So I often tell people to do exercise, and it doesn't matter what kind, really. Aerobics probably better, so do something that increases your heart rate. So 30 minutes 3 times a week. People have done trials in the Argentinian tango and various, but so it doesn't have to be the Argentinian tango. Okay. There's no evidence for stem cells. At the moment, we have no disease-modifying treatment. Those kind of trials are negative. So this is what I wanted to talk about, because this is what becomes really important later on, is what you do when it starts to wear off. Okay, so wearing off is common. It probably starts to occur a few years into the disease course, and it's when the next dose, before the next dose, you're starting to notice slowing and a tremor or just feeling awful. When people are off, it's often a internal feeling where they just feel just terrible, when it's like just feel like they want to die sometimes. It's that bad. And then when the pills kick in, they just get this surge through them that it's all great again, and then it wears off. So you have to do something. The first thing to do is increase the frequency. So that's easy. And I've said take half hour before meals. Yeah, there is some evidence in that. when you first start, I tell people to take it with meals because it's easier and they get less nausea. But there is a slight inhibition of absorption from protein. So if someone's taking it with a big protein meal, it might reduce it. But to be honest, the effect is pretty minimal. So then you want to increase the frequency. So usually starting with 3 times a day, I like to go up to 4 times a day. So a good timing is 7, 11, 3 and 7, because it's exactly 4 hours between each dose. And it's sort of around the time when people wake up. Then you want to consider adding something on top. So a dopamine agonist will be my next choice. Then maybe a COMT inhibitor, entacapone. Then maybe if they're getting dyskinesias, so they're getting ONS as well, Amantadine. So that's the usual stages we go through. There are lots of things to watch out for during that. Obviously, it's a fine balance, and you may get it wrong and go way too far one way or the other. Something called dopamine dysregulation syndrome can happen, and this is it's sort of like an addictive behavior from dopamine. So the typical person is a bit younger and they really hate being off. They'll have a pocket full of Madopas, and every time they start to feel slightly down, they'll pop one, and you get this sort of ramped up treatment, and they get a bit manic. So you have to be careful for that, and always ask for impulse control disorders on dopamine agonists as well. Yeah, and okay. So what to do if you've got through all these options, nothing's really working? What else can we do? So apomorphine is one good option. So it's not for everyone. You have to be cognitively onto it enough to set up the pump, or have someone at home who can do it for you. And it's this thing here, if you can see it. So it's like a pump, pretty sort of standard syringe driver, attached to a syringe full of apomorphine. The good thing about these new needles from Starter, the company, is that they're attached to the sticker. So you peel the sticker off and the needle's on it, and they just put it straight in. So it used to be you had to put in like a butterfly and tape it or something. It's just real hard, but this one you just go literally slap. So it's not that bad. People who are needle phobic obviously might have trouble. It can be really good at smoothing out these on and off cycles. So on average, it reduces the dyskinesias, it increases the amount of increases the amount of on time, and it just stabilizes things a bit. They can get off the oral medications to a degree. Yeah. So I quite like it. Deep brain stimulation. This is another really good treatment for the right person. Now, it's something which we have, unfortunately, very limited access to in New Zealand, and I'd love to have twice as many patients getting it, but it's for patients who are starting to get dyskinesias at a relatively early stage, and you've gone through those medication cycles, but they're still getting the on-off symptoms. So it can be really good for uncontrolled dyskinesias. Apomorphine isn't as good for that. And you want to do it before someone develops too many of the non-motor symptoms we're talking about. So if you leave it too long, they can miss their opportunity for this to be effective. Because it won't help with those non-motor symptoms, it only helps with the motor ones. And so you want someone to be not demented, no major comorbidities, have some, not psychotic. Yeah. Palliative care is important to sort of think about. If someone's starting to develop advanced Parkinson's, you want to, think about this. It's I won't read through the whole slide, but most people want to know more about it, and doctors probably don't ask about it enough. And it is a degenerative condition, Unfortunately, eventually it catches up with people. So, okay, got another sort of 5-10 minutes. So what are some mimics of Parkinson's? Not everything that looks like Parkinson's is Parkinson's. So progressive supranuclear palsy. These are pretty rare conditions, but it's important to recognise something that's not typical Parkinson's, because they may not respond very well to the medications. They may have worse prognosis and need more care. And so this is a condition caused by a protein tau, usually, not the alpha-synuclein. And they get this more symmetrical onset, early falls, something called a supranuclear ophthalmoplegia, which is just difficulty looking up or to the side eventually. Pseudobulbar palsy, so really strained dysarthric speech, swallowing difficulty, and And it can be really nasty and quite progressive. So over a few years, people can become sort of wheelchair bound and stuff. It's not very nice. Early on, levodopa may have a limited effect, but it's usually short-lived. And people have some typical sort of MRI changes eventually. So they get atrophy of the midbrain. You can see there's like a hummingbird, and this is like Mickey Mouse ears. So it's not a very nice one. This is the patient's face with PSP, so they call it the reptilian stare, which I don't think is a very nice description. It's Andrew Lee's. So we had this frontalis overactivity and just really staring, and you get her to look up and she won't be able to look up. But when you fixate her eyes and move her head, she will be able to. So that's the supranuclear bit. The muscles in that are intact, but it's a signal from the brain to the eyes that she won't be able to do it. Yeah. MSA, or multiple systems atrophy, is the other sort of big Parkinson's plus syndrome, which is a bit of a, I don't really like that word because they're separate conditions in their own right, really. It's a triad, so you get Parkinsonism, again more symmetrical. Autonomic dysfunction, you have to have that, so that's when you get big postural blood pressure drops, and they may have problems with excessive sweating, urinary difficulty, bladder overactivity, etc. And cerebellar dysfunction as well. And one of the main problems with this postural hypertension is how to treat it, and you often can't give much levodopa because they get terrible postural hypertension. They don't respond very well, and they get this thing in the brainstem called the hot cross bun sign, which is just atrophy of the tegmentum, the middle of the medulla. So this is an interesting condition, neuroleptic malignant syndrome, and it can occur in people with Parkinson's disease if they have their levodopa just suddenly stopped, and in that case they call it Parkinson's hyperpyrexia syndrome, but it's pretty much the same thing. So any sudden withdrawal or blockage of dopamine can result in this, and it's rare, but it can be an emergency. So people can become hypothermic, so get fever, hypertensive, rigid. They can become confused and stuporose and comatose eventually. And you want to check a few things in the blood test. So CK should always be up. Okay, CK will be very high. They may or may not get renal dysfunction and myoglobinuria. That's the breakdown product of muscle, goes through the kidneys and damages the proximal tubules. But there's a lot of other potential causes of someone being stuporose, so it's not always that. It's super rare, but you always have to think about it. So people with who are antipsychotics, they always are aware of this in the psych wards, and they have bromocriptine and dantrolene sort of sitting around just in case they're going to use it. Yeah. The urine may look like this. This is sort of this browny sort of myoglobinuria. This is another patient who's got something different. Wow. So she's got this postural tremor. See, it's postural tremor. It's a bit faster than the other patient. I'll just start again so you can see it. So it's a postural tremor, a bit more on the right side. It's quite fast compared to Parkinson's tremor. She doesn't look overtly Parkinsonian. Okay. So then when she puts her hands out, unlike the other patient, there's no lag. It's there straight away. So when you have a Parkinson's tremor, there's a re-emergence. This is there immediately. And it looks pretty symmetrical there. She's also got no rest tremor, which is an important point. And then she's got this. So some people will call this intention, some people call it kinetic. Kinetic is probably the better word. Intention sort of implies cerebellar, but there's no past warning. It's not a cerebellar tremor. She's got no bradykinesia at all. So she's got good movements. And you talk to her, and her mother had the same tremor, and if she really hates it because she holds a cup of tea, she spills it. She can't do her knitting. She's found that a strong brandy in the afternoon keeps her good for a couple of hours. So what has she got? Yeah, that's right. So we don't call it benign anymore because it's not benign. We could just call it essential tremor. Yeah, it can be quite disabling. So essential tremor, it's a bugbear of mine. It's quite common, comes up with age. It's got this dominant inheritance, so it's not complete penetrance, but you often find there's a family history, and it becomes worse over time. So patients often start with a hand tremor. They can then get a head tremor. It's usually a sort of nodding yes, yes tremor. They can get a voice tremor, which is at the same frequency. And they notice that it does transient and improve with alcohol. And often people become alcoholics as a result of this, trying to sort of keep it at bay. And if you follow everyone with essential tremor over time, it's quite interesting that more than you'd expect develop Parkinson's. So there's some kind of shared pathophysiology there. If you follow them over time, they often get this sort of milder version of Parkinson's. I've got quite a few of these patients. You've got this diagnosis of essential tremor maybe 10, 15 years ago. Now they've got dopamine responsive Parkinson's disease. It's interesting. The treatments are not that great, as you've probably found. They might dampen it a bit, but the side effects are quite significant. So beta blockers, dopyramate. I'd use dopyramate before I use primidone. I should change that around. Deep brain stimulation, though, can be useful, especially if someone's young and got quite severe essential tremor. I've seen people respond really well.